Hello, my name is Dr. Szilard Voros. I am an internist and cardiologist, and I have been studying cardiovascular disease, lipids and lipoproteins, genetics, and biological big data for over 2 decades now. It is well known that cardiovascular disease remains the #1 cause of morbidity and mortality, both in the United States and worldwide. The underlying process that leads to a significant proportion of cardiovascular disease is atherosclerosis, or plaque buildup, which leads to 2 dangerous consequences. One is plaque rupture, and the other is a blood clot. Now, what is a plaque? Simply put, a plaque is a pimple. It has fat, it has inflammation, and when it gets ripe, it ruptures and it bleeds. So then, what leads to plaque buildup? Everyone knows about LDL cholesterol or bad cholesterol. LDL particles are in fact the most common cause of lipoprotein particles, and as their name implies, they have 2 components, lipids and proteins. In terms of proteins, the primary protein component of LDL particles is a protein called apoprotein B, or ApoB for short. These LDL particles directly drive dangerous atherosclerotic plaque buildup. One can think about these LDL particles as these small little fat balls that literally and physically sneak inside the blood vessel to wreak all kinds of havoc. They get stuck there and they cause inflammation and plaque rupture. And we have known for many years that when it comes to LDL cholesterol, the lower, the better. Now, circulating levels of LDL cholesterol are determined by genetic factors on the one hand and environmental factors on the other. In terms of genetics, LDL levels are determined by a large number of genes with small effect sizes, and in terms of environmental factors, diet and exercise are the most important. Now, if LDL cholesterol is bad cholesterol, then Lp(a) is worse cholesterol. What are then Lp(a) particles? Well, an Lp(a) particle is just another form of a lipoprotein particle, just like the LDL particle. In fact, one can think of Lp(a) particles as a cousin of LDL particles. They also contain lipids. They also contain ApoB as the primary protein. However, Lp(a) particles, in addition, also contain a protein known as apoprotein a, or Apo(a) for short. And this is the most important thing to remember. A, big risk. So what makes Lp(a) particles carry a big risk? There are 2 relevant reasons. First, Lp(a) promotes plaque progression. And second, Lp(a) causes coagulation or clotting, leading to life-threatening thrombosis. So what do we know about Lp(a) particles? First, not diet, genetics. Circulating levels of Lp(a) are heavily determined by genetic factors. While LDL levels are influenced by a large number of genes with small effect sizes, Lp(a) levels are drastically determined by a single gene, the Lp(a) gene, with enormous effect size. And unlike LDL, lifestyle factors such as diet and exercise have negligible effects on Lp(a). Now, Lp(a) particles, just like LDL particles, also sneak inside the blood vessel wall. They also get retained, and they also foster and promote atherosclerosis. Now, the size of circulating Lp(a) particles is determined by the number of a repeating protein structure in Apo(a), referred to as the kringle for type 2 repeat. So if an individual inherits the small form of Lp(a) genetically, they will have high levels of Lp(a) throughout their lifetime. They will develop atherosclerosis, and they will develop myocardial infarction. So once again, Lp(a) represents a triple threat. It promotes plaque progression, it drives plaque disruption, and it causes coagulation and clotting. For these reasons, testing for Lp(a) is a big step in prevention. The circulating Lp(a) levels can be measured by different techniques. Techniques such as ELISA exist, and they are often inaccurate given the presence of this Kringle 4 type 2 repeats within the apoprotein molecule itself. Techniques such as electrophoresis can actually give accurate measurements of the total burden of the circulating levels of atherogenic Ldl particles, because electrophoresis is not affected by the number of these type 2 Kringle 4 repeats. So in summary, Lp(a) is the new frontier in cardiovascular medicine. It represents the ultimate residual risk beyond LDL cholesterol. There are now several novel therapies being developed by the pharmaceutical industry that drastically drop dangerous Lp(a) levels. Accordingly, measuring Lp(a) levels at baseline and on therapy will be paramount in the coming years. And just like we measure and monitor LDL cholesterol in all of our patients, we will be measuring and monitoring Lp(a) levels also in all of our patients. So in a way, Lp(a) is the new black, and remember, little a, big risk. Thank you very much.